you're suffering from craniocervical instability or upper cervical instability, so the first and the second vertebrae, and you're here on the right channel. Normally, this is a German language channel, or Kopfgelenksinstabilität. That's the German word for it. But today we have a very special guest from the United States, Mr. Centeno, from Centeno and Schultz. He's one of the most famous global experts in the field of stem cells injections in the upper cervical spine. And for this reason, this interview is going to be in English. If you need local language support with subtitles, then I show you briefly how this works. Wenn ihr deutsche Untertitel für dieses Video braucht, zeige ich euch kurz, wie das funktioniert. Now, first of all, you need to watch the video on a computer because this is not working on a TV. Also ihr müsst es an einem Computer anschauen. Am Fernseher kann man die Sprache nicht auf Deutsch einstellen. Then you go to the video. I briefly share my screen. So here is my homepage. Then you go here on a video. I briefly stop the video. Pause. You switch on subtitles. Also ihr schaltet hier die Untertitel ein. Then you go to settings. Ihr geht zu Einstellungen. Then you go to subtitles again. Untertitel. And then you can go to automatic translation, automatische Übersetzung. Here you can choose your language, for example, Deutsch for German, or any other language. It perfectly works for Latin-based languages. Maybe it will give some problems with my German accent, but with Chris from Centeno, I think there should be not a problem for the translation. All right. Then have fun with the video, and if you like the video, then give me a like and give me an abo. Hello, Chris.
Hi.
I'm very happy to have you here in the line today. I'm really honored and I'm quite excited to talk with you. You are one of maybe the most global expert in terms of upper cervical instability or craniocervical instability with the focus on stem cells therapy, and you apply a very unique treatment method by injecting stem cells through the throat, through the mouth, directly into the spine, which is really unique on the planet. I just know that one doctor in Switzerland is right now applying for the license for doing this, but this is already delayed for more than 1 year. There were rumors that somebody in Seoul is offering something like that, but this is also not confirmed. So for me, at the current point of state, you are the only one who is offering that method. And yeah, I'm very happy to have you here on the line.
Well, happy to be here.
Yeah, I mean, this is the method I would like to discuss with you today in detail. But before we dive into this method, to have some general introduction into what types of instability is there, and what treatment methods are there, For this reason, I would like to share the screen and
Okay.
We dive into this. Yeah, this is a slide from you. I mean, you have your own channel, and you have right now almost every week you have a very interesting video. This video was about the types of craniocervical instability. So you differentiate between type 1, type 2, and type 3. If you want to give us a little bit of an insight about what those types are about.
Sure. So type 1 involves the skull to the atlas, or C0, C1. Type 2 involves atlantoaxial instability, or C1, C2. And type 3 involves C2, C3. And because this entire area generally develops in the embryo as one unit with the head, Problems in these areas tend to be referred to the head, and it's often difficult for the patient to separate out what's happening here and what's happening in their head. So, and then there's different types. Each level would have a different type. So for example, a very common one that we treat is type 2B, or C1, C2, or atlantoaxial instability that can be picked up side to side or rotationally. Or another type that we see very frequently is a type 3A, where the C2-3 translates forward in flexion, or a type 1A, where there's a low clivoaxial angle in flexion. So those are examples of different kinds of instability that need specific different treatments to try to help patients recover or avoid a neck fusion.
Okay, for me to repeat this in my words, so type 1 is like you nod the head to the front and to the back, and then there is a problem by doing this. Type 2 would be you put the head to the side, and there is a problem with this. Is this correct?
For a type 2B, it would be sliding at 1-2 this way, or rotation at 1-2. For a type 1A, or like we were talking about before, a C, there's a problem between the skull and C1 when the patient comes forward like that. So so different movements would cause different types of instability to show, but where it's happening would be a type 1, type 2, type 3.
Okay. The dancing dance, which is very known here in Germany, would be type 2?
That would be a type 2.
Okay. All right. What is not very known in Germany is type 1C and D. So this is when the head is, when the skull is sliding on the first vertebrae, right? So this is what I'm suffering on. I would be type 1D, where the head is sliding to the skull is sliding to the front or above the first vertebrae. And you also had in your video here, I really can recommend the video, the different types of craniocervical instability on your channel, that this has to do with the shape of the skull. When the skull is too flat, then of course it's a more likelihood that it's sliding on the skull, and you do a calculation of the dimensions, and then you can judge about is there a possibility of the instability, right?
Correct. Yes. So this calculation is how deep set the skull condyle is on the atlas. And if it's a very deep set, that is not going to allow much movement, even if the ligaments are damaged. But when it's very shallow, if the ligaments are damaged, there can be quite a bit of sliding.
All right. So that's very new for me. It was very new for you when I watched your video, and I think it's worth to also talk about it. And then this slide is a very important one, also shown in that video, where you describe the methods of injecting. I mean, if we also go briefly through it to have more insight about what levels of difficulty do we have.
Sure. So there are lots of different areas in the neck that can be injected, everything from ligaments to joints to nerves. Now, the very simplest type of neck ligament injection would be off to the left here on the blind injections. And that's when the doctor just palpates the bony parts in the middle and puts the needle on those bony parts where the ligaments live. So that might be prolotherapy or PRP into those midline ligaments. We call them supraspinous, interspinous ligaments. Then you can also do that one over from the left with image guidance. same thing, just using either X-ray or ultrasound to guide the needle. And then one over from that, you can start to inject using X-ray guidance into the joints in the neck, plus those ligaments. And then the next one over would be same thing, but now we're adding in more complex injections in the high upper neck of those joints. And that's going to be the 0-1 and 1-2 joints. And this is where we start to get into more rare procedures, because in the United States, let's say for every 1,000 interventional spine doctors who can inject those joints in the neck, probably only 1 or 2 have injected the high upper neck with any frequency, and even then, not very often. And then we get over to the next one, or that level 4, where we're now adding in some structures in the front of the neck called the anterior longitudinal ligament, and then the deep structures in the back called the posterior atlanto-occipital membrane, or PAOM. And then finally, the level 5 on the right, so the rightmost there, is where we're injecting from the front the internal ligaments that hold the head on, the alar ligament, the transverse ligament, the deep ligaments that prevent the head from falling off, if you will. And that's one that only we perform here. And I think you were talking about earlier. So as you can see, lots of different things can be injected. And at each step, there's more skill needed and regrettably fewer doctors that can do it. And that's the seminal problem here, if you will.
Yeah. Actually, what I tried, and I'm not sure whether this is totally wrong, but I tried to do in the brackets the types of the harm, of the instability. So you would probably treat more this methods for type 3. Is this correct, or can you not do this kind of classification and those more higher levels for type 1 and type 1 and type 2?
So certainly, when I say an A, so type 3A, those are inflection problems. So any of those would map to these posterior ligaments off on the left. Then as we get into a type 4, we're starting to get into injecting ligaments in the front that would stabilize things in extension. So those would all be the Bs. So a type 1B, a type 2B, a type 3C.
And that would start here in the 4 stars.
Correct. In extension.
And you do really the injection here from the front? No.
Yes. So ALL, anterior longitudinal ligament. So let's say you had a C2 that was coming backwards on C3 in extension, meaning bring your head back. That would need that anterior longitudinal ligament injected. And the only way to get there would be from the front. And then we get into the 5th over, or the level 5 there, the 5 stars, where we are injecting the internal ligaments. And those internal ligaments control side-to-side motion. They also control, for instance, the internal structures staying together. So for example, if we're talking about the transverse ligament, that's like a seat belt for the dens against the atlas. So if that's loose, you're going to see the dens move away from the atlas.
Right.
And so that would be a problem at C1, C2. So rather than a type 2B, it'd be a type 2A.
Okay. So that's new for me. So if I look at the possibilities in Germany, we do have 2 doctors who apply prolotherapy into the neck.
Yep.
one also injecting the facet joints.
No,
but nobody, I think, from the front. Yeah.
Okay.
And I think
I'm going to try some of my bad German. Nur zwei Ärzte, only 2 doctors?
Yeah.
Okay.
Yeah. So from the front, I'm not aware that somebody is injecting here. So what I realized when I watch your videos is you really carefully analyze what ligaments are harmed, and you just do not just do any injections like with the machine gun, let's say 70 injections and cover everything, and then it should be perfect. You really carefully analyze how the structure of the instability is, and then give a proposal about the treatment.
Yes, that's the goal, because the problem is you want to expose the patient to the least invasive thing that's the most likely to work. And so if all they need is something off to the left, obviously that's easier to perform. There's more patients or more doctors that can do that. But if what they need is something off to the right, then they're wasting their time doing something off to the left.
Right.
So it's an example.
Yeah. I mean, the special topic for today is the PICL method here. I would like to highlight this here, because this is what I said, which is unique, and maybe giving patients an opportunity for some kind of healing or improvement where the other methods do not really work. Yeah. And you already mentioned the 2 ligaments that are harmed here. It's the alar ligament here, or alar ligament here. Those here connecting the skull to the dens, to the second vertebrae, and the transverse ligament. So we had our own session on the ligaments. So I already introduced the ligaments and how important those 2 are. And before we dive into those 2 ligaments, I need to say that I'm in a group of supporters. So we are here 100 people where we exchange experience of treatments. We also have a group in Telegram. I also want to give a link below this video into the group. And we exchange upright MRT or MRI pictures or reports. And what is very common here is that the dens tip, so the tip of the dens is somehow harmed. This here is a translation by the computer of my MRI statement. I'm not quite sure how readable it is, but this is very typical that the tip of the dens is somehow harmed. So it looks like, in case of an accident, like a car accident, that the dens is crashing into the skull. Or how do you explain this harm?
So I think what this refers to is the apical dens ligament. What's labeled here as and it's partially covered there, but we call it the apical dens ligament. So the dens goes up like this, and there's a ligament that goes from the dens to the skull.
Okay.
To the front of the skull there at what we call the basion, or the front of the hole in the bottom of the skull. And that's one of the ligaments that constrains the dens. Now there's many others. There's the alar ligaments, the transverse ligaments. There's something called Barkow's ligament. There's another ligament like that just in front of Barkow's ligament. So many different ligaments, but that one in particular connects the tip of the dens to the skull.
Okay, so it's not that the dens can hit the skull in a certain position.
If other ligaments, so you can have a collapse of the structure where the skull comes down, and then the dens goes into the bottom hole of the skull. Now that's usually a separate condition. That condition would be more common in Ehlers-Danlos patients, for example, or patients with severe ligament laxity. But I think what's being described here is an old injury to the apical dens ligament that indicates that there was trauma in this area.
So also typically by car accident.
Yes,
Or
correct.
okay. Because we were puzzling, you know, one guy, he was jumping into a swimming pool which was not deep enough, and so
Yeah.
we thought, okay, might be that there is some physical contact, but okay, this is obviously normally not the case. Okay, I understand this. Okay, then we come to these ligaments that we already were talking about, the alar ligament and the transverse ligament. And yeah, I mean, if we look at the upright MRIs here in Germany, so in Germany, we just have the upright MRI. So we have 5 devices here. And I mean, I know that you are using more motion X-ray. Yeah? I have no clue where I can find a motion X-ray in Germany. And so typically we see these reports where these alar and transverse ligaments are somehow harmed. Is this the dominant root cause for the instability of type 2 and type 1?
Yes, so that would be a type 2B instability with the alar ligament injury. Now realize that when we look at a ligament, we can't tell if the ligament is, many times we can't tell if the ligament is functional. So what this describes here is that there was some prior injury to the alar ligament. It tried to heal, but we don't know whether or not if we try to stretch that ligament, it functions normally.
Okay.
And that's why movement-based imaging can be helpful. Now, for a type 2B, that digital motion X-ray can be very helpful. But there are other times that a upright flexion extension MRI, for instance, looking for a type 2A, would be very, very helpful. So it depends on the type of problem you're looking for. But what this report tells us is there was some sort of injury to the alar ligaments. It tried to heal. Now we need to answer the question, is the ligament fully functioning normally?
Right. So that answers already my 4th question, because more or less, right, even if on the upright MRI it's stated that there is some harm, it's not the proof that this is the root cause, right?
It's not. So now we need to stress the ligament to see if it functions normally.
Right. And it can also be the other side, that the ligament is not functioning, but you don't see it on the MRI report. Yeah, because it's
very
not
common problem.
Okay. Okay. So you can sum up that the MRI is giving just limited information about the root cause of maybe some indication, but it's not really a proof.
Correct. Yes. And that's the problem, is that you're getting some information from the MRI. For example, let's say one morning your car doesn't start, right? And you text your mechanic and you go and you take a picture of your car engine and you send it to your mechanic. Your mechanic is going to say, I don't know what's wrong with the picture. You got to bring the car in. I will do my tests. I will see if there's something in the engine that's not working that prevented your car from starting. Same thing here. We're taking a picture of the ligament. Now, if the ligament is completely destroyed, then that picture could provide value. But we really need to stress the ligament to see if it's a problem. And so we see all the time non-functional ligaments on stress imaging like DMX that look fine on MRI.
Okay. Are there any other possible reasons why the dens is moving backwards towards the spinal cord besides the alar and transverse ligament? So could it be that those 2 ligaments are totally fine, but the dens is moving backwards nevertheless?
It's possible. Realize that the transverse ligament is the strongest ligament in the body. So it's a very strong ligament. So it would tend to override the effects of the other ligaments if they were damaged, because it's so strong. Now, in EDS or hypermobile patients, that ligament, however, can be loose like other ligaments. So you can see the dens moving backwards just because the ligament is loose in hypermobile EDS patients. But because the transverse ligament is so strong, it would override the effects of other ligament injuries.
Okay, because all reports in the upright MRI that I have seen, you have a reduction of the buffer zone if you turn your head to the left or to the right. So many cases there is a touching, of the spinal cord. In my case, I have a buffer zone of 1 millimeter. But this indicates that there must be something with the transverse ligament as well.
Yes, that could certainly be. Now realize that the alar ligaments have a wind up effect. So as you turn your head, the alar ligament partially winds around the dens. So that friction there, or that counter force, provides C1, C2 stability. So the alar ligaments are also involved in rotational stability at C1, C2 by winding around the dens partially.
Yeah. Now there is a lot of discussions. There is not too much videos on this topic in German, but there are some therapists from the mechanical side that claim that that they have a good improvement by muscular treatments of the patients, even if they had tried prolotherapy before. Is it possible that you have a purely muscular or fascious-driven instability like this?
Yeah, realize that stability of this area, or any area in the body, is half ligaments and half muscle stabilization. So you can get muscular-driven instability. Now, it generally doesn't show up like this. The ligaments are working, but the muscles aren't. So in those patients who have normal or near normal ligaments, but weak muscles, strengthening is very valuable. In those patients who have very significant ligament instability problems, usually, but not always, you have to treat the ligaments and then treat the muscles. But muscular stability is a very important part of the overall equation.
Okay. All right. Good. Then coming to your treatment, I think we discussed a little bit about those importance of the ligaments here, and there is only one way when those ligaments are harmed to treat it directly, and it's in your clinic, right?
Yeah, that's the only we're the only ones that have done that so far and perfected that technique. So that's a treatment we call PICL. It comes from the front, and so we use at first an endoscope to see the back of the throat. Then we use dual axis X-ray units, one going front back, the other going side, to image the needle. And we place that needle into many different ligaments: alar ligament, transverse ligament, accessory ligament, SAAOL, AAOM, tectorial membrane, ALL, and others that we can reach from the front in order to provide better internal stability of the damaged area.
Okay, you place the needle into this structure here, and then you just fill the room, right? Or do you change the angle of the needle?
Oh, no, yeah. So it's pretty precise. We have to get the needle in the exact right spot, and then we inject X-ray contrast to show that it's going along, in this case, the length of the alar ligament. And then once we confirm that we're in the alar ligament, we then inject bone marrow concentrate containing stem cells into the ligament to try to promote healing.
Okay, so you change the position of the needle in the structure.
Yes, the needle has to be within millimeters of a specific spot to make sure that we get inside the ligament.
Okay. Okay. So I did an this is here MRI picture of my head, and I just measured how deep you go inside the head. And
yes.
I mean, I think you start somehow here, yeah, in the throat, and then you go in, and then the question is, do you get out again at the breathing tube, or is this another structure besides the breathing tube, where you go, where you are?
So for this procedure, the patient is given IV sedation. We use a special, one of 3 different designs of a special 3D printed mouthpiece that we have created to allow exposure of the area, where you can also X-ray through the mouthpiece, because all of the other mouthpieces are metal and you can't X-ray through them. So we don't need to use a breathing tube 99% of the time. So that's not in the way. Now, every once in a while, we'll use a nasopharyngeal tube if the patient has a poor airway, in which case we have to work around that tube, but that's less common.
Okay, Chris, maybe wrong translation from my side. I mean, here is the breathing channel from the nose, right?
That. Gotcha.
And my question was, you get in here, then you get out here again, and then you get in here again, or is it a different structure?
So we would start at the back of the throat there, to the right and the left, under the atlas, and then right, left, and center above the atlas. So the needle would go in through the oral cavity into the structure. We would do our injection, and then the needle comes out, and then a second injection would be done.
And this is besides the breathing channel from the nose, right? You don't get into this again.
No, never through the nose, just through the mouth.
Okay. No. Here, I mean, this is here. I think here is where you breathe, right?
That's the nose.
Yeah.
And then below that is the mouth and the tongue.
Okay, and your needle goes besides those structure.
Correct. And realize that the picture here shows the mouth closed with the tongue elevated.
Yeah.
So once we push the tongue down, there's a much bigger space to work in.
Okay. I missed to tell you to tell here the audience that you have a video on the procedure which is describing this very precisely. I will link also this video below this video here. If you're interested, I really recommend to have a look into this. Also, this mouthpiece is then explained in detail, and also the other devices. So that's very interesting and very worth to have a look in. Okay. Yeah, how much time does such a treatment take? How long are you in anesthesia?
Yeah, so the average procedure is somewhere between an hour and an hour and a half. And during that time, the patient's getting IV anesthesia through the arm.
Okay.
So somewhere between an hour and a half. Now, we have some patients where we just do very little, and obviously that's quicker. But this is the average patient, an hour to an hour and a half.
Okay, and you're fully sleeping there?
Yes, they're fully sleeping.
All right. Okay. And probably also the head is fixed somehow that you cannot move, or?
For most patients, it doesn't need to be fixed because they're sleeping. Now, if
Okay.
the patient has any kind of head motion, we will have one of the helpers within the room physically hold
All
the
right.
head to obviously keep it still.
Okay. Is there a level of harm where you say, okay, there is no chance of healing? And what is the typical success rate of this procedure?
Yeah, so in the rare event, and this is a very rare finding among CCI patients, that the ligaments are completely torn and retracted back like a torn rubber band, then we can't help. Or we've seen a few people with problems that they were born with that are so severe we can't help. For instance, parts of bones missing, ligaments that should be there that are missing. They just were not born with those.
Okay.
Typical success rate in all patients, so that includes people who are bedbound to people who are still functional, is about a 7 in 10 chance of getting rid of the need for a fusion, meaning avoiding a fusion surgery.
Okay. So that means a big improvement for, let's say, yeah, maybe not a normal life, but an okay life.
Yeah, I mean, a lot depends on where you start, right? If you
Yeah,
start bedbound, harder to get back to completely normal. But we
right.
have patients, for example, that are still lifting weights. They're just modifying what it is they're doing. And if they do certain things, they might be bedbound. So those patients, much more likely that they're going to get back to a normal existence.
Yeah.
So we've had those types of patients go back to jujitsu, for example. One of our patients was a jujitsu instructor and went
Wow.
back to doing that. Now she
Okay.
modified it a little bit. She didn't do some of the stuff where people had her in headlocks,
Yeah.
but she still did jujitsu and taught.
Okay, good. Next question, I think you already answered. I mean, they're the stem cells from the fat and from the bone, and also I recommend a video here that you did lately, which was very interesting as well. You do the stem cells from the bones, right?
Yes, so bone marrow concentrate or stem cells obtained from the bone. As far as adipose tissue, that might work. The problem is that it doesn't seem to be as powerful for ligament healing. And then prolotherapy would not be good in this area because the covering of the spinal cord is there, and that's the dura. And so prolo can kill off small nerves. So we
Okay.
wouldn't want to do that.
Okay. Okay,
And
because there's a
then,
lot of discussion, Chris, and I'm very confused about applying it from the back because most of the prolotherapists say that prolotherapy is even better than stem cells or PRP. I mean, you did a video where you say PRP is better than prolotherapy. So that's very
yeah,
confusing for me.
so listen, I've been using all of these, prolotherapy, PRP, bone marrow stem cells, culture expand stem cells from fat. We began using stem cells back in 2005. So we were the first clinic on earth to do these types of stem cell injections. And through the years, the example I give is SI joint instability. So if we have a patient with SI joint instability that's female, if we use prolotherapy, it's going to be 6 to 8 visits to get that SI joint stable in the pelvis. If we use PRP, it's going to be half of that. So somewhere around 3 to 4 visits for that patient. If we use bone marrow concentrate, it's going to be 1 to 2 visits and we'll be done.
All right.
So that gives you some idea of the relative strengths of these. And that's pretty consistent with my colleagues that use all of these different things. Now, one of the things you've got to be careful about, let's take PRP, is that the dose of the PRP matters. So if I've got a 45-year-old patient and I use 2 times concentrated PRP, I'm going to get a very weak effect. Prolo might be better than that. But if I use 10 times concentrated PRP, then it's going to do dramatically better than Prolo. So that could be what those doctors are talking about. Maybe they're only seeing the lower concentrated PRP kits being offered to them.
Yeah, and I think you also need to do a video on the PRP. Yeah, because I think really the device makes the big difference, and maybe in our group of supporters, PRP is more ranked down, because maybe we just visited therapists with just 2x concentration, so
A
2
low
times
dose,
concentration.
yeah.
So we really
So
need
that's
to
a,
look.
that's
That's
a
really
good idea. I think I will do a video just on PRP dosing and what that means and how it compares to Prolo or bone marrow concentrate. So
right.
that's a good idea.
After the treatment, you need to stay in your clinic, or how this works?
So basically, the patient comes in the morning. We do a hands-on evaluation that takes about an hour. And that's to hone in on the structures we want to treat, to again review all the imaging. So prior to that, we've had a telemedicine with the patient. That telemedicine is something like this, where we're looking at their images, planning out what we want to do. Then the patient comes into the clinic. We do another hour or so focused on honing in that plan and making it better. Then the patient will get a bone marrow aspirate done. That takes maybe 30, 40 minutes. They'll be put to sleep for that with an IV. They go to recovery. They're in recovery for about a half hour to an hour. And then they've got some time to spend with family, etc. And then they come back in the afternoon, where we perform the procedure. And the procedure takes an hour, hour and a half. And then they're in recovery for somewhere between an hour to 2 hours. And then they're discharged back to the hotel. Now, every once in a while, we'll see someone that needs a little longer assistance, so they may stay at the clinic a little later.
Okay.
But the goal is an ambulatory procedure, and that means a walk-in, walk-out procedure, so that they can spend the night in their hotel. Now, if they have any problems, they're free to call me. We've had a very small number of patients that need to be checked that night. But more commonly, if there's any issues, concerns, the patient comes into the clinic the next day, maybe we'll start an IV to hydrate them because we're at altitude here. Or like I did with a patient this week, I needed to check the back of the throat. So a patient came in the next day, that looked fine. They were discharged to go back home.
Okay.
So that's generally how that works.
Okay. A question that is not written here, but it popped up for me right now is like, when the stem cells are in, how much time do they have to find the right spot until they die?
Well, they don't die. So hopefully they stay and integrate. So when it comes to your own stem cells, autologous, the current research shows that they will stay in the area and integrate into the local tissues. Now, if we're using allogeneic stem cells or someone else's tissue, then the body does target them for death or destruction. And in that case, they release chemicals to try to promote healing for a week or two. But when it comes to your stem cells, they will stay in that area, and the goal is to get them to live in that area.
And how long would it take that they find their right spot?
Well, they need to be placed at the right spot.
They are already in the right spot, and then they need to connect, right? Okay.
Correct. So what they would do is 2 things. One is they would act as like a construction manager or a construction contractor, in that they're barking orders to other cells about what to do and how to do it.
Right.
And then when they're done, they can differentiate into ligament tissue. So that means that when they're done, they turn into the bricks and mortar.
Right. I mean, I had already 12 or 13 injections with PRP in the neck from the back, and a doctor, yeah, sadly he passed away during the procedure, not during the procedure, but during where I was a patient, and he was claiming that, you know, that there is some repair of the ligaments in those structures, but you know, the harmed structures, they somehow forgot how they can repair themselves, that they are look right. And then you need to inject stem cells that have the knowledge of how the structure looks right, to give guidance to the other structures and then to multiply the repair. So he explained like this. For me, it was
Yeah, so the stem
understandable.
cells, yeah, so the stem cells take their clues from the local tissues as to what they're supposed to do. So for instance, we know through mechanobiology that if you apply stretch to stem cells, they're more likely to become muscle or ligament tissue. If you apply compressive force, they're more likely to become bone tissue. So that's how they determine what it is they're supposed to be.
Okay, now very important question, because you know, nobody else is doing it, and the others all claim it's too risky. It's too risky because of infections in the throat, inflammation, so they don't do it. So what is your experience about the complications? Yeah.
Yeah, so I always answer this question relative to fusion, because that's the procedure that we're trying to replace. So let's start with fusion. So if we have a C1-C2 fusion, in our experience and what's published in the literature, there's about a 1 to 2 out of 10 chance for a serious complication that would end you up in the ICU, in the hospital, in the intensive care unit, and about a 3 or 4 out of 10 chance for some life-changing thing like chronic pain in the occipital nerve because that nerve had to be sacrificed. So we've had about 900 of these procedures done. No patients end up in the ICU. No serious problems or issues, other than we have about a 5% group of patients who, because they're very sensitive, have a prolonged flare-up in their symptoms lasting more than 3 months. And when we followed up with those patients, most of those patients are eventually getting back to their baseline. But these are the same patients that flare up with lots of other procedures as well. Now, what are the theoretical risks? It's certainly possible to get an infection. Haven't had that, but it's possible. It's possible to damage a structure we're not supposed to. But that's why we take all of these precautions that we take. So it's definitely much less risky than fusion, and it does require a high level of expertise. So for instance, before I ever tried this, we were doing the high upper cervical posterior injections for decades. So yes, I think it's a new procedure, and because it's a new procedure, and because it broaches new territory for spinal injectionists, meaning ear, nose, and throat doctors, for example, inject inside the mouth, as do dentists routinely. But to the average spinal interventionalist doctor, that's pretty daunting, right? They've never injected anything inside the mouth. That just sounds like something they're not qualified to do. So we've got lots of equipment to do this safely. The risk is not zero, but so far the risk profile has been dramatically better than fusion.
Okay. Thanks. Yeah. Yeah, I mean, I need to ask this question, and I know that you cannot give a precise answer, but it's probably not the case that you just need one injection, right? So you
Yeah,
need
so
more.
there's a 1 in 5 chance, 20% of a one and done injection. So about 1 in 5 of our patients only get a single injection and then don't get or need more. There's a 4 in 5 chance that you will need more than one injection, and the average number is somewhere between 2 and 4 procedures.
Okay. And the distance between the procedure is like 2 months, 3 months, 1 month?
Yeah, usually we would like to see 3 or 4 months between the procedures to make sure that the patient maximizes their healing from the first injection.
Right.
And we really determine that they really need a second procedure before offering another.
Yeah, I mean, the stem cells, the good stem cells need to divide. And if you have, let's say, 3 months, there's, of course, a higher amount of, yeah, good stem cells, right?
And just longer for the tissue to
Right,
heal.
to heal. Yeah, exactly. Yeah. Then coming to the price, I know this is not cheap. Of course, it's a unique treating method, and then also it's from the bone. This is also much more difficult to get the stem cells from the bone and more cost intensive. So can you say something about this?
Yeah, so now a lot depends on what it is we do, but if we're talking about the PICL procedure, then the cost for that is $12,500 per procedure US. Now, for other procedures that we perform, cost would be much less than that. So the cost for the patient really depends on what type of instability we're treating. But for PICL, it's that 12,500 US dollars.
If this needs to be combined, because if you have certain instability, like shifting the head, you would do it this procedure, but you would also apply from the back. So the price would then be 12,500 plus the injections from the back. So something like 15,000.
No. So the 12,500 would include the front and the back.
Okay.
Now, there are some patients that come in and say, I want my neck injected, my shoulder, my left knee, my low back. Obviously, that gets to be a different price. But we're talking about for PICL and doing front injections, the back is always included.
All right. Then also not here, but also, because we are talking, I'm also thinking, of course, if it's the likelihood is just 20% to have it done by one procedure, could I just already buy a bundle of 3? And would it bring costs down that you just say, okay, you can just make more, bring more bone stuff out, just do it one time and then freeze the stem cells for the second and the third procedure, or always needs to be done this before the procedure?
Yeah, now, in the US, we're not allowed to freeze the cells down or multiply them in the lab. Now, we do that in our in a clinic that we staff in Grand Cayman, and that's where I'm going next week to treat patients. Now, we don't offer this procedure there because they don't have the proper equipment necessary to do this procedure, which is a lot of equipment. So where we do this procedure in Colorado, we have to take the bone marrow each time.
Okay.
And that's through US and EMA regulations. So the US and the EMA regulations would be the same on that.
Okay. All right. Okay. So I think this is all answered. Yeah, very in detail. Some common questions, maybe we need to strive briefly because it's relevant maybe for overseas patients. So they typically fly in, no? Then get used to the time, then go to the consulting, as you said, in the morning, and then at the afternoon it's the procedure.
Yeah, so for international patients, we recommend that at the very least you come in the day before, maybe 2 days before. And then we recommend for the first procedure that you stay through the week. So we perform these procedures on Tuesdays and Wednesdays. So we wouldn't want you heading back home until Friday or so. And that's so that we have the opportunity to check on you if needed before you head back home on an international flight.
Right. Is there something you need to know? You're not, you should not move the head a lot, or don't do any movements, or is there any regulation?
Not there. So it's really activity is tolerated so that you can really continue to do what you normally do. Now, I don't want you training for the Boston Marathon.
Yeah, it's clear. Nobody can do this.
Yes, but it's more going back to what your body can tolerate, not having to wear a collar, not move the neck, that kind of thing.
All right. Very important also, I mean, not everybody is fluent in English, especially on those topics, a lot of different words, yeah, ligaments and vertebrae, yeah, so that's not the vocabulary that you normally have. So people are maybe unsecure. How do you handle this?
Yes, so we can bring in a translation service through a phone app.
Okay.
Another option cheaper than that, obviously, is just using Google Translate. We've done that. And then many of our patients, the German or the Swiss or the Scandinavian patients we've seen travel with somebody who maybe is a little better in English.
Okay.
And we work through all of those things to try to make sure that they understand what's happening. In addition, we have a very long document that we can give the patient that they can obviously get translated as well.
Okay. All right. Good. Then also very important question is, of course, you carefully think about to fly to the US before you do this. And the question is, do you some kind of remote diagnosis where I can just send you the pictures? Typically, as I said, in Germany, we don't have motion X-ray. We just have the upright MRI pictures and the report and maybe a functional X-ray. Is this possible? How much does this cost?
Yes. So almost always we recommend, whether the patient's in Germany or within the States, that we get on a telemedicine visit just like this. We go over all of their images. We go over the questionnaire that they fill out, which is quite extensive, their medical history, and then we can determine whether or not they're a good fit for this procedure before they fly out here. Now, sometimes we'll need to get additional imaging. And so, for example, we just had a Chinese patient who was able to replicate something close to a digital motion X-ray locally there. We also have X-ray protocols that we can give European patients to take to the hospital to see if they can get some of the views that might give us additional information or replicate what a digital motion X-ray might show.
All right.
So that's generally how we work. And then we just, I think 2 weeks ago, I had a German patient. That German patient spoke some English, but he had a friend who was, I think, maybe even part of your group, who stepped in and helped to translate for him online.
Okay. Yeah. I mean, we have a mother with a son who is suffering on very heavy headache, who's in your treatment, but he had just got one injection, so there's no experience that we can already give. But I mean, if we have the results here, I would like really to also interview her. We will see.
Sure.
You have a kind of references where you can say, for example, in Europe or in Germany, where you can say, okay, This is somebody you can have some kind of X-ray pictures that we can use, or you have just this description how it should be done, and then you are looking to hospitals and ask for how whether they can do it.
More the latter. Now, there is a very good functional MRI in London. The MedSerena MRI is good there. I also understand that there's a good functional MRI in Barcelona where Dr. Gillette is. So those are two other options for different types of imaging.
All right. Okay. Last question was, so you do offer this, and what would it normally cost? Of course, it's depending on how comprehensive it is, right? How many hours you need to analyze this, but what is the typical cost just to have this analysis?
Oh, so that runs $275 US. So the goal there is a 40-minute consult with me to go over all the imaging, over the answers to an extensive questionnaire, medical history, etc. And then either we can get to a diagnosis of craniocervical instability, or we may need more information, or we can discuss next steps of treatment. Those are all possibilities.
Okay, and I also learned from also a colleague in my group who is in contact with you that you can pay this by credit card as well, so you don't need to do money over the bank.
Yes, you don't need to do a wire transfer.
Yeah, because this costs already, for $250, it costs another $200 for transfer the money. So credit card is very convenient there.
Yes.
All right, good. Yeah, I think we covered a lot. I think last thing is whom I should contact to have this kind of consultation. I think in your videos you already mentioned always that you should contact Clara directly, right?
Yeah, I am part of a large clinic here, and we do lots of different things. This is one specialty area. And because CCI patients tend to have a lot of imaging, they tend to have a lot more intensive needs around what it is we need to see. It's better to reach out to my assistant directly, Carla, because she can help coordinate all of that. Sometimes going through the general clinic, it's much harder for them to understand. For instance, someone who works in my clinic might know what a knee MRI is and how to get that. But when it comes to a functional upright MRI, flexion extension views, and then a head coil to see if there's a problem with the alar ligament, that's going to go over their head. So Carla knows what to do.
So here you see the email address of Carla, and I've already been in contact with her, so the communication is very good.
Yes, she's great.
Chris, I think we covered very much everything I prepared. Did I miss something? Did I miss something which is very important you want to say to cover, which is,
No, I think pretty comprehensive. Listen, our goal is to try to help people avoid fusion, and we don't offer a panacea, but the treatment seems to be very effective for some patients. As you talked about, we're very focused on specific diagnosis of which ligaments need to be treated. So no, I think you did a great job, and hopefully the German patients can start to get engaged with this, because you're right, the language barrier creates less opportunity for treatment, I think, for many German patients.
Yeah, and also in my group, I'm okay. I'm relatively okay, but some people are really in deep trouble.
Suffering.
Let's say like this, and they say, okay, they've tried everything here, but they're not able to fly. So what we're missing, Chris, is you here in Europe.
Yeah, well, I will be in Europe April 23rd, but not doing this.
For conference.
So And I don't have a European license to practice medicine, just the United States.
That's the problem. Also here, a lot of regulations, especially with stem cells.
Yes.
So this is really, to get here license is really, really difficult.
Yes.
Anyway,
I will be
really,
I will be in Spain April 23rd.
yeah, maybe for vacation is also a nice spot there. Yeah.
Yes. Exactly.
But actually, really, I'm very happy. As I said, I was very excited about this interview because you're really the pop, yeah, of the stem cell therapy in the upper cervical area. And it was really a pleasure, and thank you very much for your time to spend this here. Yeah, as I said, it's really my target to increase the knowledge, and I really want to stress and emphasize once more your channel, where you really post almost every week now very interesting topics, and you also give the opportunity to give questions. Yeah, what I still was missing is to go into the live chat. So is there some kind of announcement of your videos where you can then dial in, because I always miss the point of time?
Oh yes, and that's hard. The time difference is substantial, right? So I'm on it at 1 p.m. Mountain Time. And what's the time in Germany right now?
It's 8 hours difference.
So yeah, so that's already 9 p.m.
Yeah,
your time.
which is still okay. So still okay.
So it'd be 9 p.m. your time. So I am on Mondays, 9 p.m. your time, and Fridays. Now, not every Monday and Friday. So for instance, this next week, I'll be in Grand Cayman seeing patients at the clinic there. And I may do one impromptu, but I will be, and this is maybe an opportunity, I will be in Europe for 6 weeks, April 23rd. So that'll be on your time. And so what I'll be doing there is some pre-recorded videos with some live Q&A once a week that is closer to your time frame. So I'll be answering pre-recorded questions from the US, but I'll be on during the day for that 6 weeks, once a week. So that might be a good chance for your group to get in some live chat and live Q&A with me. So that'll be starting April 23rd through June 2nd. I'll be on your time zone answering live Q&A, and I'll send you some information about that.
Sure. Is there an opportunity to meet you in person for some consultations?
I don't think it's legal for me to do that.
In
now,
Germany,
we will be in Spain and the Balearic Islands during that time.
Anyway.
So
yeah.
anyone wants to come down to Spain, I'm happy to go out and have some coffee and say hi.
If they can make it to Spain, they can also do it to the US.
Yes.
All right, then. Thank you very much again. And yeah, we keep in touch maybe. Yeah, we check the reactions of the video. So if you like the video, please give us a comment, give us a like. And yeah, thank you very much.
Okay. Thank you so much. Bye-bye.